Every single talk that we've had today so far has probably made my work a bit easier to bring this to everyone. And one of the interesting things that I must say, listening to everybody, is the fear factor that I bring in when I walk into the room. And it is very realistic. It is something for everybody to kind of know that once any of the other people have called me and I walk in, there is a straight change on my examination. I have to accommodate for straight fear. Because the first thing they look at me and they're like, okay, I'm the kidney specialist who's walked in, and their just fear is dialysis. Okay? And one of the things we have to keep in mind is don't fear it. It is feared because of the mythology of starting it too late. Okay? Right. So my declaration is basically I am on invite from SOMPA. Thank you very much for the invite. So going into the introduction, I'm going to tackle this as a diabetic kidney disease. And what we need to understand about this is it's a leading cause of kidney failure. We have to understand where nephrology came from in the beginning is it was housed under endocrinology and under diabetes, and then it grew into its own big human on its own. So one of the three things that we look for in diabetic kidney disease is the persistent albuminuria of more than 300 milligrams on 2 occasions, 3 to 6 months apart, progressive decline in eGFR, and an elevated arterial pressure. The prevalence, as we have seen on every other slide that everybody has given you, is continuously on the increase. And if we are projecting forward to say that there is going to be a 55 increase in diabetics, we know that the end result of all of those people is some sort of kidney decline. So it's something that you must keep in mind to be very cognizant so that you don't end up making them scared when you call a nephrologist too late. You call them early. Okay? There is now a substantial amount of diabetic kidney disease that is not proteinuric, and this even has it at about 48%. But you still have an eGFR, which you have seen Dr. Abdullah has given on several of the cases where the eGFR is less than 90, it's in 70, 60, and there is no proteinuria. So this is something to keep in mind. The risk factors we know are so many, from the demographics, the hereditaries, and the systemics, hyperglycemia, obesity, and hypertension. There is the kidney injuries and the first, second, third hits in terms of acute kidney injuries, toxins, smoking, and then the high protein intake, which we are all discussing about how you can lose weight, increase your protein intake, but it does have its effects on the kidney, and I'm happy that Betty brought that up in one way.